welcome to the latest BJA broadcast. In this talk, what I'm going to do is focus on the July 2021 issue of the BJA. And here on the screen, you can see the cover. And the particular article that's grabbed my attention in this issue that I'd like to expand on is one that's come from a group of authors based in New York. And to readers of the BJA, they will by now be a familiar group led by Stavros Mentsoudis. And the paper that they published this month is called Hip Fracture Characteristics and Outcomes During COVID-19, a large retrospective national database review. And I'm delighted that Stavros, along with Jaswant Puran, have been able to join me for this discussion. And perhaps I could ask you to introduce yourselves. First, Stavros.
Yes, thank you, Phil. My name is Stavros Mentsoudis, as you already mentioned. I work at the Hospital for Special Surgery in New York, and which is basically a teaching hospital affiliated with Cornell, which is just across the street, New York Hospital, Weill Cornell Medicine. So I have an appointment at Cornell in the anesthesia department, as well as the Department of Public Health. And, at the Hospital for Special Surgery, I serve as an anesthesiologist and the head of critical care. And as Phil already mentioned, our group has been working on similar topics for a long time. I think I started this over 20 years ago, the whole idea of database research and epidemiology and related to perioperative medicine. And it's been more and more exciting and successful by the year, and especially because I get to work with smart people like Joshua.
Okay, Jaswant.
Yeah, thank you, Phil. And thank you for your interest in our studies also. So I've been working with Stavros and his team now for 8 years. I'm an epidemiologist with an interest in perioperative health services research. I work at the Icahn School of Medicine at Mount Sinai in New York as well. I'm an associate professor and director of the Center for Clinical and Outcomes Research, which is a collaboration between two departments in our institution, the Department of Orthopedic Surgery and Population Health Science and Policy. Yeah, I guess that's it.
Okay, that's plenty. Thank you both. So obviously the context for this particular paper is the COVID pandemic. And before we get into the details of the paper itself, I think people would find it quite interesting just to hear from you the context as it affected you and how the COVID pandemic impacted on New York, because I think it did have quite an impact, didn't it?
Yes, it did have. It basically changed our lives for now almost a year. But in March of last year, like in so many other countries in the world, the pandemic really hit here and transformed our hospital from being a specialty orthopedic hospital to a COVID hospital, basically. I, being a critical care physician, really, it was probably the most, challenging part of my career, where we converted operating rooms into ICUs and basically switched from routine orthopedic care into critical care of COVID patients. However, being the largest orthopedic hospital in the country, we continue to perform emergency orthopedic procedures during that time. So especially cases that needed to go, hip fractures, which is the theme of this paper, were a big challenge for us because these patients needed surgery during a time where resources were scarce, and we just basically had to reinvent how we were doing things. And our experience was obviously one of many. But using this database allowed us to look at what was actually going on through this country and see what happens when we are in situations where resources become a problem and our attention is focused on other urgent things. And the question then becomes is there something we can learn from that? Because we live oftentimes, I feel like, in the land of plenty, where we don't have to think about things twice. And I reach around and have all resources available to me. And this was really a truly challenging time because it made you rethink a lot of things. Now, hopefully, or thankfully now, we've kind of gotten almost back to normal. And this is almost feels like in the distant past, but I think it changed all of our practices, it changed us personally, and it changed our outlook on many things.
Okay, so before we get into the details of the study on the impact of the pandemic on hip fracture patients and hip fracture outcomes, I'm really interested in data. I love data, and I really do envy you that you've got access to what seem to be some fantastic databases, and I don't know that they're reproduced anywhere else in the world. So can you just give us a little bit of a background of how these databases came to be, and how many are there, and what the pros and cons of the different databases are?
So perhaps I'll give a little bit of an overview of the types of databases that we have worked with in the past, and then I'll let Joshua talk a little bit more about the details of this particular data set and what make them particularly useful for these type of questions. So in the United States, we are lucky that we have a large number of databases that are fall into a number of different categories. So if you want to divide them into those that are run by the government, there are ones that are have been collecting data since the 1960s, Medicare databases, for example. Then we have the the AQI, quality institutes and quality initiatives through that provide and collect these data on a large scale, hospital discharge databases that all serve different purposes. Many of them are administrative in nature, so they're basically are mostly serve the purpose of collecting data from a commercial or from a financial point of view and allow for policy making. Then there are databases that are were set up by societies. The Anesthesia Society here, for example, has one as well in the United States. The surgical the surgeons have a very famous one, the NESSCRIPT database, the National Quality Improvement Project. And then there are commercial databases, and those are ones that in the last few years have become particularly interesting for us because they contain so much information in respect to all kinds of charges that are being levied on patients and insurers during a hospital stay. In the past, the problem has really been that anesthesia type information was very difficult to come by. But if you kind of rethink it from the perspective of everything that is being performed in a hospital is being charged for, and you can find charges that are related to anesthesia practice in those databases, then use that information to look into anesthesia-related questions, which when you looked into government type data sets was really not the case. So you see in the progression in our work from 20 years ago, it was very much a perioperative outcomes type research to more recently in the last, I'd say, 6-7 years, we really have focused on anesthesia-related outcomes. And the two data sets that we've been working with recently and successfully, I think, are both commercial data sets. It's Premier and it's Truven. And I'm going to let Josh elaborate a little bit more why those are so exciting.
Yeah, no, so thank you for that overview, Stavros. Yeah, I would say the biggest difference between the government databases and the ones that are commercial is the ones that are from the government, and people have thought about what are the variables that are that should be available in these data sets. What we see with these commercial data sets is that it's basically everything that's being built for, right? So there's no active thought process. Well, maybe to some extent, but not as much as with the other data sets. The differences between, so why we sometimes use Premier, why we sometimes use the Truven market scan data set is, I mean, there's several reasons. The main reason is that we can follow patients longitudinally in a market scan. So that's one reason. The other reason is also the patient population. It's somewhat different in Premier than it is in market scan. Market scan represents commercially insured patients. So not those on Medicare. So you have a generally younger patient population. So if you're interested in stuff like hip fractures or other fractures that are more often seen in elderly patients, you know, market scan data would not be the main source of information. You would then have to go to either Medicare data or Premier data or another data source where you know that they're represented. There are more differences, but I guess that would sum it up, the main difference between those two data sets, right, and the bigger difference between commercial and government data sets.
Right. The other thing I should say, Premier has been a very good data set to look into perioperative type information, because there's a lot of information included that relates to any sort of charge during a hospitalization of a patient, while but doesn't allow really much for longitudinal analysis. So it's often like, you know, you see these papers and we focus on perioperative outcomes, and then one of the criticisms always like, you know, what about longer term outcomes? And that's where you know, data sets like Truven are more interesting, because they do provide information on a patient for as long as this person is insured, and it's basically the data is available on a patient level, while as from Premier it's more like on a hospital level or hospitalization level. So the longitudinal follow-up is more difficult to do. There's some things that you can follow up for up to 30 days or even 90 days, but most of it will be just during the hospitalization. So it depends always what the question is. And obviously, you know, we've worked with many more data sets, and I always describe this as, you know, when you ask a question, you have to also know what the you know, what are your resources that will allow you to answer this question. So whenever we ask a question, we then kind of look into a library of data sets and pick the one that will allow us to answer that question most accurately and most completely. And we've also done projects in the past where we have combined information from data sets, where we've you know, looked into, for example, you know, reintubation after, you know, neck surgery, and in those settings, we've looked into institutional data sets from HSS, because that provided us with quite a bit of detail in terms of clinical detail, in terms of you know, laboratory values and vital signs, which is not available in these larger commercial data sets. So clinical details are really something that you would have to get from institutional data. And then obviously we combined that in order to get the big numbers and look into care that is not just specific to one institution, but has a large external validity, you know, data sets like Premier.
Okay, so I mean, I'm assuming that there are standard procedures for enabling researchers to access these data. I mean, I think that's one of the hurdles that a lot of researchers face when they're wanting to access large data sets, especially commercially derived data sets.
I would say the short answer to that, the main standard procedure would be relates to money. So it does cost money to access these data sets. But they are available for researchers at a discounted rate.
Okay. So no matter which data set you're using, you've got potentially a huge amount of data. What are the challenges that you face, or one would face in handling such large data sets?
I think there are many, right? I mean, first of all, what people need to understand is just having access to a data set is only one portion of the whole work, because the data does not come in a way that it's you know, just basically plug and play. You have to manipulate the data. Manipulate sounds like it's a bad word, but in this case, it really means that you have to get the data set ready so you can actually ask the question, answer the questions that that you're interested in. So that requires often a lot of upfront work. So when I have people ask me from other institutions and tell me that they're interested in obtaining a data set and then do a project, I will tell them, like, be a little careful, because it's going to take you a lot of time upfront to get the data to the point where you can use it. And I encourage you to think beyond just one project, because once you have the data set ready, you may be able to answer a number of questions that are related. And it's just from an efficiency perspective, I don't think it makes sense to just basically go after one question and then do all the work, and then you also get excited about it, because what I find with these database questions is always like you answer one question, then end up with 10 more. So that's number one, is really you have to be aware of the resources it takes and the time it takes to get your data ready. And on the other side, you have to be very aware of what questions are answerable. Often as clinicians, we have questions that are very lofty and that we want the answers to, but data sets or databases are very limited in terms of what they can answer. I cannot make up variables that do not exist, although having said that, I can actually, to a certain extent. They're called string variables. So I take some information or combine different types of information to create new information. And I can explain that perhaps a little later as we talk about the paper. But for example, if you're not sure if somebody got what type of anesthesia they got, rather than looking for a billing code that says general anesthesia or regional anesthesia, I can also look at, charges for, let's say, a local anesthetic or a spinal needle, and things that are related to a regional anesthetic that then would, suggest that this person really got a regional anesthetic without it specifically saying this was regional anesthesia. And there's other examples like that. Josh, do you have anything to add to that?
To the challenges, you mean, or to the use of proxies to create variables?
Yeah, I think both. The challenge.
Yeah, no. So that, I mean, the challenges, I think, so Stavros summed up, I think, the main initial challenges, but then you have challenges also related to interpretation, right? So you can look at, we look at things that are built for example, that doesn't necessarily mean that it was actually administered. So you have to keep in mind what are the limitations of the information that is in these data sets. So that can be a challenge sometimes. Also thinking about why interventions are applied. So then you have to come to the issue of confounding. Generalizability. So I think the use of these data sets brings with it lots of generalizability that you wouldn't have in trial data or single institutional data. So that's a plus, but something that also to keep in mind, and we see that in lots of our studies also, there's a very heterogeneous group of hospitals that are represented in these data sets. And that's not necessarily this data set, that's just our healthcare system. We still see that there's so much between hospital heterogeneity in care and lots of factors that are unmeasured. So whenever you do a study with it and you want to answer a specific clinical question, you have a set of variables that can help you answer that questions, but there are a lot of other variables that are not measured in the data set. So you want to be aware of the things that are not measured as well.
Do you have any ways that you, or tricks that you use to gauge the rigor of the data? Obviously, any data set is dependent on how the data is input into the database. So do you have ways that you can quality assure or validate the data? Yeah,
there are several ways. So sensitivity analyses are, I think, the main important thing that we try to do in our research group is that, if you use an alternative cohort, for example, or a select set of hospitals, and see the same signal or the same effect estimate or the same direction, just to be sure that what you're seeing in your main analysis actually is a robust finding. So sensitivity analyses but also just comparing univariable, so unadjusted data to adjusted data. You know, if something completely changes direction, you want to figure out what's going on. So having a good understanding of why it is that you see what you're seeing. And there are, so you have other ways of sensitivity analyses as well. So using additional types of analyses, you know, propensity score analysis or instrumental variable analysis, in addition to just the regression analysis. So there are ways of trying to look at the robustness of your result.
And one thing I want to add is that as a clinician, I think we're often not aware of the huge field of methodology. You know, we are kind of, you know, as anesthesiologists or, you know, physicians in general, when we look at our clinical journals, we seem to be quite behind in terms of the application of new methodology. You know, I look at, like, you know, something, you know, the advent of meta-analyses in the early 2000s. And we, like, for us, it was like, you know, this big new thing and everyone started getting into it, when in reality, this methodology existed for decades, you know, in the field of epidemiology and methodology. You know, then same thing with propensity analyses. And we tend to, you know, kind of be behind in terms of adopting like these new methodologies in a timely manner, and then they linger for a while before we accept new ones. And that is something I found that has accelerated quite a bit, that, you know, through database research, because database research is highly dependent on using adequate and appropriate methodology. And it's no longer enough to do, like, you know, t-tests and you know, even ANOVA or something like, you know, it's fairly simple that we used to use for clinical trials. This has become really like a matter of keeping up with current methodology. And this is one of the things that, you know, Joshua probably referred to in terms of how do we make sure that our data or results are robust. We basically use different methods to ask the same question, because most of the time there is no such thing as the right way or the wrong way to do an analysis. You know, this is something we really had to learn, and you know, in order to you know, see if our results, for example, were dependent on the type of method we used. We, you know, often go out of our way and, like, you know, use 2, 3, 4 different methods. And if the results always come back the same way, you know, we feel a lot better about it, rather than just, you know, one method showing significance and the other one doesn't, or God forbid, even the opposite.
Okay, that's great. So now we've got the clinical and societal context for the study. We've got the methodological background for the study. So let's get on to the really interesting stuff, and what you found when you were exploring the impact of the COVID-19 pandemic on hip fracture patients and their outcomes.
Yeah, so obviously, you know, there were a few findings that were, you know, not surprising, but interesting, right? Number one is that the number of the cases that we saw of hip fractures was halved. So we didn't see as many hip fractures as we did in the pre-pandemic era. And, you know, a logical explanation for that was that, you know, the stay-at-home orders that we saw everywhere. So people weren't actually as mobile. In the you know, setting of hip fracture surgery, you don't also know if, you know, hip fractures that previously would have shown up at emergency rooms, you know, did not. They stayed in nursing homes or at home. We just don't know that. But there is some good evidence that we generated ourselves, looking into, like, you know, utilization of ICU resources during the pandemic, and what the impact of actually stopping elective surgeries would have been on ICU utilization. We saw that trauma played actually a big role in this. And the reason why we were probably able to cope and with you know, with the pandemic, as well as we did in terms of ICU capacity, was that trauma pretty much went away. And the reality is that, you know, hip fractures were a big part of that trauma. So that was the first finding. So hip fractures in general went down. Then, the other thing is obviously like how did these hip fractures fare during that time period? And one thing we saw is that the decreased utilization of resources. People didn't end up in ICUs as much anymore. They went home earlier, which basically then started to make us think about like, well, if they can go home earlier, during a pandemic, and they don't have to go to ICUs, were we overusing these resources during good times? And should we rethink these things? And then, not a surprise, obviously, that those patients that ended up with COVID-19 and had a hip fracture, that they fared a lot worse than those without COVID-19, basically having more complications. Those are, I think, the big findings. There's some nuances in there. Joshua, do you want to add anything to that?
Yeah, so I think that's the main message. The nuances, yeah, there were no difference in outcomes. I would add there also in terms of when we would compare March and April 2019 to March and April 2020. So outcomes after hip fracture surgery. So 30-day readmission, mechanical ventilation, and a composite variable of complications. That was not different between the two groups. And the patient characteristics were the same also. Right,
which basically even begs the question even more of, were we wasting resources beforehand if we can achieve the same outcomes, sending people, utilizing ICUs less and sending them home earlier?
To be completely honest, I was expecting actually some differences in patient characteristics during so in 2020 compared to 2019. So I was actually a little bit surprised that we didn't see that, because there's so many different factors at play. You have the stay-at-home orders, you have people that are moving and people that don't moving. So I had actually expected perhaps more elderly patients, and more sicker patients that actually do get a hip fracture in 2020. The more vulnerable patients that would experience this in 2020. But our data proved that there was no difference.
Okay, so I think those are fascinating. I mean, and it is a really hot topic at the moment with many countries and health systems trying to evaluate what's happened in the pandemic and the longer term consequences of the pandemic on health and on how we can manage patients with healthcare problems. Are you finding in general, Stavros, that have you got a big backlog of patients waiting for surgery who haven't been able to undergo the procedures that they would have done if the pandemic hadn't been around?
Yes, the short answer is yes. And it's also the type of patients we see. So we've had like a big backlog on on sicker patients, because during the immediate aftermath of the pandemic, where we started opening up and doing some elective surgeries, we selected the healthier patients and the younger patients with the idea that we wouldn't require as many resources. The chance of them ending up in ICUs and blocking beds and utilizing our resources would be smaller. So now what we're seeing in the last few months, though, is that group of patients that have been postponing their surgery or had been postponed by us, the sicker patients, the older patients, that they're really coming back with a vengeance. So we see actually an uptick in our utilization of the ICU and also the experiencing complications, but that's because we really now see this flood of sicker older patients catching up with their needs.
Okay, thank you. So before we finish by talking about the sort of some of the other issues that are perhaps generally applicable to this type of research, I just want to bring in your paper from the June issue. And this is, again, another database study. I think used a different database, but opioid prescribing in general is really topical at the moment. And what you've done, and it's the first that I've come across an exploration of this association, is the sex differences or the impact of sex on perioperative opioid prescribing. And again, this is a really topical and important subject area. And I just wonder if you could just tell us a little bit about some of the findings that you had with that study.
Sure, Josh, you want to talk about this, or?
No, I can definitely talk about this. Yeah, so we looked at around 80,000 total joint arthroplasty. So that's kind of we do studies in other cohorts as well, but the majority of our studies is in total joint arthroplasty surgery. So we looked here in around 80,000 of them using the market scan data set. And we looked at opioid prescribing before, so in the year before surgery, what was prescribed at discharge after surgery, and chronically prescribed opioids, and how this differed between men and women. What we find is that preoperatively, female patients were more often prescribed opioids in the year before surgery. At discharge, this changed to higher doses for males, and chronic use was more often seen in female patients. So there were patterns. It was not a consistent pattern, but there were patterns of sex differences in opioid prescribing in this cohort.
Yeah, I mean that's really fascinating. Have you any theories to explain the differences you found?
Yeah, well, the thing is like, whole topic of disparities in healthcare does not only apply to racial disparities and social disparities, but does also apply, gender differences. And and some of these differences, I mean, there have been like descriptions about pain perceptions, and also pain pathways, that there are differences, maybe differences between men and women. However, that is all nice and well, but I think there's always this big risk of bias amongst prescribers, right? People make all kinds of assumptions based on their context, the way they grew up, the way they perceive certain patient populations, and that is the thing that we really wanted to highlight. That when there are differences, the question then being, why do these differences exist, right? And especially if these differences are associated with different outcomes, right? So we know chronic, pain and the chronic opioid prescription is a major public health problem, right? So it's not only like, so if I do something and Joshua does something else, but there is really no difference in the long-term outcome, who cares, right? That's just whatever practice differences. But if it's unwanted differences or variability like we have here, we really have to question, what is it due to? And more specifically, is it due to something that we introduce as physicians as a bias? So now, like, why could this be? Like, why do we see the differences that we see? So why do women get prescribed more opioids before surgery than men? Is it because physicians feel that women don't cope with pain as well, and therefore require more opioid prescriptions? Is it that men are more hard-headed and therefore don't want the opioids? Clearly, it's not. At discharge, we have like a good suggestion that that's not the case. Men don't feel less pain than women because they actually go home with more opioids. So after the fact of surgery, we do see these differences. But then, you would expect, if you go home with opioids more frequently, that in the end you would also end up, using these opioids for a longer term and become a chronic user. But that is not the case again. So now we see women again being in that group that actually is prescribed opioids more frequently, and then perhaps that is again linked to a bias in terms of how women deal with pain versus men. Again, there may be real differences in terms of pain perception and metabolism and all these other things. What I just highlighted here, and a little provocative, I think, is it a judgment about what men and women feel in terms of pain that leads us to these prescription patterns. And those questions really need to be asked. And the data set doesn't answer that, right? We don't know the reasons of why we see what we see, but we definitely see that there are differences. So now it's up to us in the next step to investigate why this might be. And other specialties have done this to a much better or much more extensive degree than we have in anesthesiology. Surgeons, cardiac surgeons have, looked at this, in much more detail of why is it that we recommend surgery to certain racial groups more than others, and accept the fact that there are differences in outcomes. Anesthesia is really, the field of anesthesia is really in its infancy when it comes to disparities research, and this is one contribution to this.
But one thing that struck me about your findings is whether this points to what happens for prescriptions for acute pain in the perioperative setting and in the postoperative period may be a lesser factor in chronic opioid dependence than everything else that is happening to a patient. So this acute intervention, there's been a lot of concern about it, actually may not be such a major factor in the overall problem that you've described.
Right, I agree. I mean, the thing is, the reason why there's so many factors that actually play into development of chronic pain and pain behavior that I think it would be foolish for us to think, we as anesthesiologists, I think, are important, but we, what happens in a couple days in a patient's, health course, we may put a little bit too much weight into it. Long-term outcomes, we have shown, for example, that the way we perform peripheral nerve blocks may not really have an impact in the long term. Well, perhaps we're doing peripheral nerve blocks wrong. Perhaps we have to make them last longer. And Ed Mariano, for example, has introduced this idea of matching pain management to the trajectory of pain, right? If I know that a patient's going to be in pain for, over a certain threshold for 2 weeks, what's my one-day block going to do really? Is that really going to make a difference? And it's true for many outcomes. So giving ourselves too much credit and not questioning, the other factors that may play a role, I think is a problem. Cancer recurrence is another one of those fields, right? We find these huge effect sizes when we look retrospectively in terms of people getting regional anesthesia versus general anesthesia. And then you talk to oncologists and they shake their heads. They have we have this non-specific intervention that lasts for a few hours and it's supposed to have these huge impacts. And then the oncologists have these very targeted interventions, and they're jumping up and down when they achieve a 5% reduction in recurrence or mortality. So one has to really ask these questions and not, patting ourselves on the back is nice, but I think we really need to be also very critical about the conclusions we draw from these data.
Great. Okay. So I'm coming back now to the more general value and interest in the type of research you've been doing. And one of the things that you mentioned earlier was the difference in the healthcare settings, the different types of hospitals that are included in or contribute data to the databases. And I was just wondering whether you've got a real grasp of the disparity in healthcare. Is it geographical, or is it dependent on the socioeconomic status of the patients, or the types of hospital? What do you think? What's your feeling for that sort of question?
I think, Josh, this has been kind of your field of interest quite a bit.
Yeah,
So
it's a very general question, but I would say it kind of depends on the context and the specific question and what type of disparity we would expect. That there is a clear biological evidence base for what we found in this study, for example, differences in pain perception and pain experience between men and women. But when you're looking at complications, disparities in complications, for example, or disparities in utilization of specific perioperative interventions, um, it really depends on what the question is, but we've seen disparities in other contexts as well, and it could be geographic, just differences in practice patterns in different parts of the country. It could be hospital based, there's a specific protocol in place in one hospital versus another hospital. It could be based on specific patient characteristics, older versus younger patients, men versus women, even racial or insurance type. So it kind of really depends on what the specific clinical context of the question is. But I mean, they are pervasive. Not sure if that really answers your question.
Well, yeah, I think so. I think you've given a very clear picture of the differences are there. The power of the databases that you've utilised is certainly sufficient to indicate that there are differences there, and obviously they can't answer why they're there or necessarily, but they're there. And as Stavros has mentioned earlier on, you're generating perhaps a lot more questions than you're answering, which is always great for future research. I mean, going on from the potential for differences across the US, how do you think these results may be relevant to other countries, or what provisos would you suggest we put on translating your findings to those in other countries?
Well, I do think some of the data is translatable because, patients are patients, and, we medicine doesn't, like the intervention of medicine associated with medicine, tend to be, at least in the Northern Hemisphere, or like in the Western world, fairly similar. However, that doesn't mean that we can't ignore the impact of healthcare systems. The UK, Canada, are probably much more homogeneous in terms of the delivery of care, but you probably would be telling me that even there you have a lot of differences. But so looking at the outcomes in as a whole, and we probably see a good average of healthcare, knowing that if we actually go down and look at specific hospitals, specific regions, specific insurance types, we see all those differences in the United States. But as a whole, I think the healthcare outcome of interest, when taking these factors into account, and this is where methodology becomes important, I think they do show a clear picture, and they are therefore applicable as an average to other countries, especially those that practice similar medicine as we do. The one thing that makes the US, obviously, as you mentioned, unique is that we have many healthcare systems within the healthcare system. So there is really no healthcare system per se, and there's many studies, like one recently published by Dr. Rob White from across the street, Dr. Hemmings' colleague, who looked into the whole idea of safety net burden, which is basically the idea of that there are hospitals who serve communities that are disadvantaged in terms of insurance, or those that actually take care more to a larger proportion care of government insurance, which is associated with less reimbursement. So often those hospitals do not, are not financially as secure as hospitals. And he was able to find that safety net burden, the more government insured patients you take care of, the worse the outcomes, right? Now, interestingly, he also finds that, like often anesthesiologists will then say, well, that's not my problem. But there was also a finding that those hospitals that perform, that take care of more government insured patients also perform regional anesthesia less, which we now know is associated with differences in outcomes. So it's not so easy for anesthesiologists to hide anymore and say, well, not really my problem. I don't choose how much money a hospital has and how they practice. So our role as anesthesiologists in the wider public health sphere, I think, is pretty much cemented at this point. And rather than just saying that, I'm not part of this and I only have limited impact, I think it's time to charge forward and kind of take our responsibility seriously, and also kind of define the impact that we have and really profile ourselves, I think, because we do have quite a bit to offer when it comes to public health, as the pandemic has shown, right? Suddenly, like, you have an anesthesiologist on the front of Time magazine. That doesn't happen every day either.
Okay. So the question I like to ask all authors at the end is, what you're planning to do next?
Well, there's a
Probably
few.
already doing it, but
we always have a few things up our sleeves. I mean, we never really do one project after the other. There's always concomitant, but the nice thing about data sets or databases is that the second the topic becomes hot, you can jump on it, especially if you have the infrastructure in place, you have the data sets already clean, that you can answer many questions. So the last meeting last week, we were talking about looking at the impact of the perioperative use of cannabinoids, as that becomes a more and more accepted medical approach, and it gets legalized in many states in the in the US. That's going to become more and more of something that we have to deal with anesthesiologists. And these databases allow us to get a jump, a little sneak preview, again, by describing things we see, not by explaining why they are the way they are, but by identifying problems, identifying probable associations with complications, and it kind of frames the field. And then we have frequently seen that with this type of work, where the first paper may not have answered any questions, but outlined many of the problems and has sparked interest in fields like that. Joshua, can you recall any other recent ideas we had and things that we put on our list to work on that might be of interest?
I just very specifically to this context about disparities, since we're talking about this right now. It's good to have the anesthesia literature is actually, I feel, now catching up on the disparities. But then the next step would be, are there any specific things that we know that have actually reduced disparities? So that's those are things that are worth looking into. Are there any specific policies, any specific new designs of payment structures that have standardized care, protocols even that have standardized care? And theoretically, when you standardize care, you would see fewer disparities, right? So that would be a good, nice step which you could use these data sets for, to see if that had any difference, or if there was any difference over time in disparities. So that's one thing. We're working on so many different projects, which I guess it's a luxury position to be in.
And just to kind of tag on to what Joshua said in terms of the disparities, where again, our methodology and our experience is important, because, a couple of years ago, for example, we did a project on looking at ERAS components and the impact on outcome, right? So that project required a lot of work that we needed to do in order to be able to answer ERAS related questions. But now this is in our repertoire, in our library. So now, for example, when Joshua talks about standardization of care, and ERAS is, ERAS components are one such standardization. We can basically go now back, use that tool, pull it out of our drawer, and apply it to the topic of disparities. So this is something we could theoretically have an answer to within a week or two by using a big library of variables and data sets, and do some preliminary analysis at least. But that's kind of an example of how our group works.
Okay, well, that's absolutely enticing, really, as in terms of what you might be telling us about next. But for now, we've come to the end of our discussion today. I've really enjoyed it. I've learned a little bit about the importance of methodologies for database research. It certainly does seem to open a lot of opportunities for researchers if you do have access, but it also perhaps carries some health warnings here for the researcher, or for the naive researcher, that you need expertise for this type of research. And that's come across very strongly today. And it's illustrated how we can answer really topical questions. And as you've just pointed out, answer topical questions very quickly. So very exciting. I look forward to seeing what you publish next. I hope more of it's coming to the British Journal of Anaesthesia. But for now, Stavros and Joshvant, thanks very much again. And so it's goodbye from all of us here. Bye-bye.